Good afternoon, and welcome to this month's Northern Virginia Health Policy Forum. My name's Jim Scott. I'm the president and CEO of Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. My colleagues and I host these gatherings every month to share thought leader views on developments in 21st century healthcare. Today, we have two guests from the Centers for Medicare and Medicaid Services, specifically the Centers for Medicare and Medicaid Innovation. The first is Dr. Purva Rawal. She's Chief Strategy Officer at the Innovation Center, and Dilli Sundaramurthy, who is Special Assistant to Dr. Rawal. So let's start off, first of all, Dr. Rawal, can you tell us a little bit about yourself and how you came to be Chief Strategy Officer at the Innovation Center?
A lot of luck, but first I'll just say thank you, Jim, for having us here. It's a great chance to be here with the Northern Virginia Health Policy Forum, and I also want to say thanks to Dilli, who's going to introduce himself, for joining as well. Jim, I'll just tell you a little bit, I guess, about how I got here, and maybe for others that might be interested in public service as well. But I'm a psychologist by training and a health services researcher, and when I was leaving academia, I got a fellowship and had the privilege of working on Capitol Hill for 5 years. And my last job was on the Senate Budget Committee working on the Affordable Care Act, and actually on parts of the statute that authorizes CMS Innovation Center. So in some ways, my work is coming full circle. But it was an amazing opportunity. But after 5 years on the Hill, I sort of looked up and didn't feel prepared to go back into academia or seeing patients. And so, I'd gotten the health policy bug. So decided to continue in this area, but really wanted some private sector experience and exposure. I didn't have any. And, as many of your forum members know, a lot of the work that we do in healthcare has got a private and a public component to it. So I actually went into teaching and policy consulting for the next 10 years. And then I had the privilege again about 3 years ago to come back to public service. And my interest has long been in value-based payment and care, and how value-based care can be a mechanism for improving health outcomes and quality and the sustainability of our health system. And so here at the Innovation Center, I support our team in implementing our strategy, which we released in 2021, and I'm happy to talk more about that in a bit. I also lead our health equity work, which I am especially proud of and can also talk more about. The health equity work is a really key part of our strategic objectives, and I think right now in particular, we have such an opportunity to test new ways to meaningfully narrow disparities in access and outcomes. And for those of you that are interested or thinking about public service, and how you get a job like this, the best advice I got from a mentor was to do what's fun, and to do what's consistent with your values, and to always be looking for new opportunities. So I don't know that I had a grand plan, but finding areas that you're interested in, getting experiences from different perspectives, and always thinking about how they might apply in a policy setting or to public service, I think is at least one way to go.
Thanks, Purva. And Dilli, you also spent some time on Capitol Hill. Can you tell our audience a little bit about your experience there and what led you to change the executive branch, and maybe also a little bit about what does your role as special assistant entail? What are the sort of daily activities and jobs?
Yeah, let me start with that piece, actually. In my role, first off, I lead our decarbonization and climate resilience initiative, which kicked off with our team model, which we'll probably get to later in this presentation. And outside of that, Purva and I work on a number of different projects within the Innovation Center. A lot of it is helping our model teams take things from the ideation phase all the way through to fruition, whether that be a discrete model, a cross-cutting model initiative, a data project, an evaluation project, troubleshooting issues that may arise in implementation or model launch, and the list goes on and on and on. But the general idea is that these are big picture questions that the center needs to answer in order to execute on its strategy, its vision, and successful models within our portfolio. Prior to this, I was a health policy advisor to Leader Schumer. I was a second advisor, and I also led his veterans care work. I was there during an incredibly busy time, starting at the very beginning of COVID-19 in April of 2020, all the way through last August, and got to work on what I would consider an entire career worth of legislating in just 3.5 years. So that's everything from COVID-19 to the Build Back Better agenda, Inflation Reduction Act, Bipartisan Safer Communities Act, spending bills, NDAAs. Probably one of the least discussed but most important things that we got done, the largest veterans benefits package since the VA's creation and honoring our PACT Act. Worked on a lot of abortion and women's rights issues, and then ended my career with some work on the 2-year budget deal known as the Fiscal Responsibility Act. It was a great time, very rewarding, 3.5 years in Congress. But there are some health issues that we don't get to work on in Congress and that regulators in the executive branch really take a lead on. Things like physician payments, hospital payment, future of Medicare, value-based care transformation. Those are all things that are mostly led out of agencies like CMS. And I felt that to learn more about these issues, I needed to come over to the executive branch side and met with Dr. Fowler and Dr. Rull and others, and found that the wide range of interests and projects and the work environment that our leadership has fostered in their time here made it a great place to get that experience.
Thanks, Dilly. So, Purva, you mentioned the statute that established the Center for Medicare and Medicaid Innovation, and now it exists as Section 1115A of the Social Security Act. And part of that section says, the purpose of the Innovation Center is to test innovation, payment, and service delivery models to reduce program expenditures under Medicare and Medicaid while preserving or enhancing the quality of care furnished to individuals under such titles, Medicare and Medicaid. Can you tell us a little bit about how the Center for Medicare and Medicaid Innovation does that, and just sort of level set with what is the Innovation Center?
Yeah, happy to. So as I said, the Innovation Center, and Jim, you quoted Section 1115A very well, was established in 2010 as part of the Affordable Care Act. And the goal of the Innovation Center, our mission is to test new approaches to care delivery and payment reform to improve the quality of care that we provide to our Medicare and Medicaid beneficiaries while holding program costs level, or even hopefully reducing program costs. So our models are designed to improve patient care, to help ensure that people have access to high quality care. And we do that by rewarding healthcare providers for delivering that high quality and cost efficient care. I will say that our payment and care delivery models that we test are time limited tests, right? We're seeing if this is an improvement on fee for service or on the status quo. If a model achieves any of the scenarios that you outlined that are written into the statute, improving quality while maintaining cost, maintaining quality while reducing cost, or hopefully improving quality while reducing costs, the Secretary of the Department of Health and Human Services, or HHS, can expand a model that we're testing both in scope, so it could become a national program, or over time, including making them permanent. So I like to think of the Innovation Center, when we think about the Center for Medicare and Medicaid Services, as the R&D component. We can be testing things that have the potential to impact the Medicare and Medicaid programs, even nationally. When I think about our reach in 2023, we had more than 116,000 providers participating in our Medicare fee-for-service model. We had over 7.3 million people with traditional Medicare receiving care from a provider in these models, and almost 1 million people, approximately 900,000 people with Medicaid, were receiving care from a provider, plan, or other organization that was in one of our Medicaid models. So our reach is broad. We've tested over 50 models in our first little over a decade. And, again, I'll talk about our strategy in a little bit, but the goal is really for us to be learning from these tests so that we can continue to meet those statutory objectives in our North Star. Thank
you very much. And one of the key things Medicare is doing is moving towards value-based care. Dilly, can you tell me a little bit about what value-based care means and how that's different from the care provided under the original Medicare fee-for-service program?
Sure. So at a high level, value-based care offers us the chance to reimagine our current system, which is the fee-for-service system, which is essentially a pay-by-volume system, right? So, if you're a hospital or a different kind of provider, you are delivering a service and then you're billing for that individual service. What we're able to do with value-based care is, we're through the waivers that we're able to provide to the Innovation Center are a few things. We can provide upfront investments for infrastructure and data that help providers identify the sickest patients most likely to be hospitalized or readmitted. We can offer regulatory flexibilities that let providers care for patients in a home setting, for instance, or a non-traditional healthcare setting. We can offer tools and data to better coordinate primary care and specialty care and care provided by community-based organizations. A lot of it is offering payment innovations. So, capitated payments, upfront payments, quality-based outcome or quality outcome based payments, health equity-based payments, things like that. And then we also additionally have population-based payment incentives that reward better outcomes, higher quality, better patient care experiences, and so on and so forth.
Great, thank you very much. And we're going to use throughout the conversation the word model, and that the Innovation Center has models. Purva, can you tell us a little bit about what we mean when we say the word model?
Yeah, so another good word, another kind of term for it could be a pilot program or a demonstration, right? We are testing changes to payment, care delivery under our statutory authority. You quoted Section 1115A. We have the ability at the Innovation Center to waive certain payment rules in the Medicare program, offer some regulatory flexibilities. We pair that with changes in payment and value-based payment. And then we test whether or not there's been a change in quality and or spending that would allow us to hopefully, be able to either expand an entire model or scale successful features of something that we're testing. And we can talk a little bit about some of our models as well to give folks an example. But again, I go back to that point about us being the R&D component and really thinking about what we want the health system to look like in 5 or 10 years. What are some of the pain points for providers and for patients in the health system? And how can we be testing different ways of addressing those pain points or helping build the infrastructure over time for what we want the system to look like in 5 or 10 years? But when we have models and we think about people that are participating in our models, they can include physician practices, they can be hospitals, they can be groups of providers that are coming together to form entities such as ACOs. And then we also have some models that are focused on health plans. And on the Medicaid side, our participants are often state Medicaid agencies themselves, and states themselves are actually our model participants. So depending on what we're testing, the population that we're testing it with, who the participant in is can look a little bit different.
Thanks. And can you say a little bit about where do the ideas for these models come from, and do stakeholders have an opportunity to suggest ideas or engage on the model development?
Oh, absolutely. We have multiple points of input. So I'll give you one example. Sometimes we will use official requests for information, or RFIs as they're called. And we'll put an RFI out with, a 30 or 60-day period where we're taking comments and suggestions in response to these questions from the public. And sometimes that's one way, and a kind of an official public mechanism for us to be able to gather input on a model. And so one of the things we just proposed a little over a month and a half ago, was a new mandatory episode-based payment model. And that we were able to propose that using feedback from a request for information, or RFI, that we issued last summer. We also have meetings all the time with external entities. I can't tell you how much time Dilly and I both spend meeting with either model participants, people that aren't in our models, that have ideas and new concepts. We host listening sessions throughout the year where we also gather ideas, or there's areas where we're hearing that there's need, and then we'll engage with experts in that area, including beneficiary groups, experts and advocates, to really understand what the problems are that we would want to be solving for. So lots of formal and informal mechanisms for us to be crowdsourcing and generating ideas.
And in general, when a doctor or hospital or another provider wants to participate in a model, what's that process like? Is there an application or how does that work?
Yeah, it can, it's a little bit different for each model, but usually most of our models are competitive in terms of, especially our voluntary models are competitive. So there's an application process, a request for application comes out. And then we go through a screening process and look at how folks have responded to the application and then accept a certain number. In our mandatory models, which we have a few that we've proposed this year and have a couple that we've had in the past, that's a little bit different. It's not an official application process. There's a selection of certain participants, but the vast majority of our models are voluntary. Now, when we have state-based models, we often have a notice of funding opportunity that goes out to the state. But again, state Medicaid agencies apply when they have a NOFA, when they have a notice of funding. And again, usually a competitive application process.
And also, going back a little bit to value-based care, most beneficiaries now get their Medicare through Medicare Advantage. Are Medicare Advantage plans always considered to be value-based care or only some kind of Medicare Advantage? And does the Innovation Center also have innovations for Medicare Advantage as well as fee-for-service?
We do. We have an entire division actually dedicated, I think it's the Division of Health Plan Innovation actually, that does work in the Medicare Advantage Part C and Part D space. We have a robust value-based insurance design model that actually that we're testing with Medicare Advantage plans. And we're learning a lot about health-related social needs and supplemental benefits through our MA VBID model, as we call it. I don't think we necessarily assume that just because somebody is in a Medicare Advantage plan that it equals value-based care, right? Because when we're thinking about value, we are thinking about the dimensions of quality and outcomes and cost. And so even though Medicare Advantage plan might be getting a capitated payment at the plan level, we don't necessarily know if there's value-based care incentives that are baked into arrangements between a provider that might be in network for Medicare Advantage plan and the plan itself. And so actually our colleagues in the Center for Medicare recently released a request for information, a Medicare Advantage data RFI, and I believe that comment period is still open. Where they're asking a number of questions. We've been working with them as well on some of the things that we would want to know and to learn about what Medicare Advantage plans are doing with providers and how we can, understand how we can support those plans and providers in those networks to moving to value as well.
Thanks. Yes, that deadline that comment period is still open. The deadline is May 29th. So if you have comments, please respond to that Medicare Advantage RFI. I noticed from the website that there was a strategic vision that seemed to be refreshed in 2021, but now that it's 2024, is that still the strategic vision? And can you tell us a little bit about what that vision is and how you're working to achieve it?
Yeah, I can hop in and answer that one. So you're right. So in 2021, the Innovation Center announced a strategic refresh, and it was based on a lot of work done to review what had been done in the first 10 years of the Innovation Center to set the stage and begin a work plan for the next 10 years. That strategic refresh included 5 core objectives, which now guide our implementation of our vision to drive a healthcare system that achieves equitable outcomes through high quality, affordable, person-centered care. The first of those objectives is to drive accountable care that results in delivery of whole person integrated care with accountability for outcomes and quality as well as total cost. So going back to your earlier question about whether all MA plans qualify as value-based care, that is a different version of that question is whether those MA plans would qualify under this accountable care definition. We have a very specific technical definition, but which I won't get into here. But the summary of it is that, our accountable care definition essentially encompasses, total cost of care, patient-centered, focus on higher quality health outcomes, and the longitudinal relationship between the provider and the patient. With that definition in mind, we set a bold target having 100% of Medicare fee-for-service beneficiaries and the vast majority of Medicaid beneficiaries in one of those accountable care relationships with a clinician by 2030. So in 2022, we started with the ACO REACH model, which has seen a lot of growth. We've recently announced and will soon launch in July the Making Care Primary model. We've announced the AHEAD state-based model, which is a follow-up to some of our other state-based models, like the Maryland model and the Vermont all-payer model. And we also recently announced last month, I believe, the ACO PC Flex model, which is our latest ACO model tested in the shared savings program. So those are all big steps in the path to achieving that 2030 100% goal. The second objective we have is to advance health equity and improve healthcare quality. This is a priority for CMS, and it's one of the administrator's strategic pillars for the entire agency, not just at CMMI. And in pursuing that, we've embedded health equity in all of our models through a few key features: data collection, health equity plans, payment adjustments, and so on and so forth. Our third objective is focused on supporting care innovations that enable delivery of person-centered integrated care. The idea is to give participants access to actionable practice-specific data, payment flexibilities, and peer-to-peer learning collaboratives to share best practices. Providers need access to these kinds of tools to support delivering care consistent with their patients' goals and preferences, which, as many of you already know, can vary from community to community. Our fourth strategic objective focuses on ways our models can address affordability by addressing healthcare prices and reducing duplicative or unnecessary care. That's partly done through access to high-value care, such as primary care and preventative care, and referrals to high-quality specialty care. But it can also mean, intervening in, for example, some of our drug models, like our $2 generic drug model that was announced as part of an executive order made by the president. Our fifth and final objective is focused on how we will partner to achieve health system transformation. So the general idea of that is, we have an understanding that we need to collaborate with patients and beneficiaries, providers, plans, employers, states, pharmacies, suppliers, the whole of the health system in order to achieve the kind of system transformation that we're looking for. And this goes back to your earlier question, right, of how model ideas come to fruition. We take that collaboration very seriously, and we try to keep those lines of communication open as part of that fifth strategic objective.
Great, thank you. And so you mentioned the goal of having all Medicare beneficiaries and most Medicaid beneficiaries enrolled in accountable care relationships by 2030. And we've only got 6 years left. So where are we now, and do you think you'll make it?
Good question. We're over halfway to our goal at this point. There's a reason we made it our first objective. It's because it's the most important objective, in large part because it creates the vehicle that allows us to make progress towards the other 4 strategic objectives. We focus most of our models on those that can facilitate the kinds of longitudinal accountable care relationships that go into that definition. So that includes our ACO and advanced primary care models, first and foremost. And the goal there is threefold: making sure patients have a provider that is quarterbacking their care across care settings and across other providers, making sure their healthcare needs are addressed, which oftentimes means addressing their health-related social needs as well, and finally, that they receive support for their individual patient-centered goals. There's still a lot of work to be done. To get the rest of the way there, we are always continuing to add more pathways for providers to join our models. So again, we announced last year our Making Care Primary model, which comes online this July. We have the state-based AHEAD model that I mentioned earlier, which aims to amplify Medicaid-led advanced primary care efforts by aligning Medicare fee-for-service and other payers at the state level. And then once again, we have the ACO PC Flex model, which is a voluntary payment model within the shared savings program that'll allow new and renewing low revenue ACOs that are in MSSP to apply to the model and join. And as part of that model, they would be part of SSP and the PC Flex model, just to be clear. So that model tests how improving payments for primary care impacts health outcomes, quality, and costs. It's designed to empower participating ACOs and their primary care providers to use more innovative, team-based, person-centered, proactive approaches to care. We're also working to grow participation from providers who haven't historically joined our models. And the main two ways we're doing that are by first, growing participation by safety net providers to improve access to care for underserved populations. And by underserved populations, we also include rural areas as well as historically disadvantaged communities. For example, in the PC Flex model, we made sure that the model design included ways we could support rural health clinics and FQHCs who do deliver that care to those underserved populations, but don't receive fee-for-service payments. The other way that we're trying to expand the scope of our participants is by executing our specialty strategy, which was first published in 2022, and we've recently updated in a health affairs article, I believe, right, Prava? I think that was the right journal, a few months back. That includes a few elements, some of which we've already started implementing. And those 4 elements are, first, enhancing specialty care performance transparency to facilitate integration with advanced primary care practices and accountable care organizations through the provision of data that's relevant to those practices. So in February 2024, we released our first set of what we're calling shadow bundle files that include episode level data and benchmark prices to our ACO Reach and SSP ACOs. The second element relates to acute episode payments and condition-based models. So in July of 2023, we launched the EOM model, and we're launching the guide model, which is focused on dementia, this July. And in the episode-based payment model space, CMMI is in the first year of a 2-year extension of the BPCIA advanced model. And we are currently in the middle of the comment period for the recently proposed mandatory bundle payment model, the transforming episode accountability model, which is now in the FY25 IPPS proposed rule. The third element of that specialty strategy is creating financial incentives within primary care for specialist engagements, which is going to be a big part of our Making Care Primary model. And lastly is creating financial incentives for specialists to affiliate with accountable care organizations. And for that element, we are still exploring design features and policy opportunities to execute on that aspect of the specialty strategy.
Great, thank you. And Purva, you know, health equity, we've mentioned a couple times, it's the first pillar of CMS's strategic vision. Can you tell us about your role specifically in improving health equity, and then how the Innovation Center is working to do that?
You know, Billy gave a great overview of the Innovation Center's strategy. I'll say that health equity is a priority for across the administration and is the first strategic pillar for CMS as an agency and a priority for our administrator, Chiquita Brooks-LaSure. The way that we are operationalizing that priority, you know, as Dilly described, the second strategic objective that we have is health equity. And we spent a lot of time talking about accountable care, Jim. And I really think about accountable care and health equity as very much intertwined. If we want to improve quality, we have to be focused on narrowing disparities, and that means really promoting and advancing health equity. One of the key ways for doing that is to make sure that our beneficiaries have access to longitudinal care relationships, especially advanced and high quality primary care. So one of the things that we did in 2022 was launch a health equity initiative. And the overarching kind of vision for that health equity initiative is that we are embedding aspects of health equity in all of our models and across all of our models, like within a model. And the way that I think about it is when you're designing a new payment model, you asked earlier, you know, what do we mean when we say a model? Well, there's lots of different aspects of designing a value-based payment program or model. So you're paying differently. So there's payment-related levers that you can pull to advance equity. There are quality measures. There are other requirements. There's data that you can give back to model participants. And all of those, there can be an aspect of advancing equity. And so I like, you know, think of it as looking across all of those levers and which levers can we pull to test ways to narrow those disparities in access and quality. And the health equity work centers around, four kind of main areas. The first is, again, embedding equity into all of the features of models. So I'll just give one example. One of the things that we're doing at the Innovation Center, starting with the ACO REACH model that Dilly had referenced, and all 9 of the new models that we have announced since last June, is adjusting payment. So socially risk adjusting payment, or having health equity related payment adjustments in all of our models. And that means in a model, you might be getting a new, PMPM, or per member per month payment of some sort, a care management fee. In our big ACO models, we have benchmarks that set spending levels. You can adjust all of those for different dimensions of need. And so we use a combination of geographic level indices and individual level factors to say, if you are a provider that is caring for a population, an underserved population, then you would get a higher payment because you might have a population that's higher need, but also we know there's been historical underinvestment in underserved areas. And so, again, we're trying to better resource those providers to close those gaps. We also have requirements in our models for health equity plans. I think of these as organizing tools that our providers and entities in our models can use to really understand the needs of their populations. What are the disparities in access, access and outcomes that the people that they're serving are experiencing. And then the health equity plan helps them then identify those disparities, identify interventions to address those disparities, and then track their progress over time. And early on, we've been getting a lot of good feedback that this has really helped organize, again, people's thinking, help them identify disparities that they may not otherwise have known or zeroed in on as part of their work. Dilly talked a little bit about safety net provider participation. I think this is a really important one. When we first started in on our strategic refresh, as we were calling it back in 2021, and we were looking at what we needed to do in the health equity and the disparity space, we looked back at who was participating in our models. And for many of our models, we found that we were not reaching a representative group of our beneficiaries. So, in our ACO and primary care models and in our shared savings program, I think we were finding that the beneficiaries that were in those models tended to be in urban areas, more white, more affluent. And so we, if you want to, again, get to your accountable care goals, your quality goals, your equity goals, you have to reach a more representative group of beneficiaries. And the way to get to those beneficiaries is our safety net providers. And so across all of our models, we've been doing a lot of work to be able to not only make safety net providers eligible for our models. In some cases, they weren't in our previous primary care models, but beyond eligibility, how are we designing for them to be able to come into a model and to be able to succeed? Again, using payment and other mechanisms, quality reporting mechanisms. We've been working a lot with our colleagues in HRSA, the Health Resources and Services Administration, on this work as well. But that's really core to all of, across all of our new models and our redesigned models. The third issue is data collection. And we know that in order to have effective interventions, to monitor our progress, we and our model participants need accurate data. The gold standard here is self-reported sociodemographic data collection. And so we have requirements in place in all of our models to collect self-reported demographic data. I think that's gonna, and then in some cases in some of our models, we are now starting to provide stratified data reporting back to our model participants so they can, again, use those kinds of data in concert with the other pieces of our health equity plans that we've put into place to, again, monitor progress. And then the last is evaluation. One of your first questions was, what's a model? What does the Innovation Center do? We have a statutory requirement to have an independent evaluation of all of our models. We have to see if they're working or not, and are they meeting those statutory criteria for success. And so the more accurate data we have really allows us to be able to say more about our impacts on disparities from an evaluation perspective.
Thank you. And then Health Affairs is running a series of articles on ACOs all throughout last year and then also into this year. And one of those articles was talking about health disparities and the use of the Area Deprivation Index. And I think that's what you were talking about how CMS decides how to encourage ACOs to enroll safety net providers by adjusting payment for like the beneficiaries who would likely use those safety net providers while reducing payments for the other end of the ACO of the area deprivation index scale. And the article basically said, it looked to me like it was saying that overall, this is a good direction to go, but in cities like New York and Washington, D.C. and San Francisco, it's not precise enough and can sort of make it, the South Bronx look like it's part of a bigger area, even though it's the poorest congressional district in the United States. And therefore, you wouldn't get an adjustment to your payments for enrolling a provider in the South Bronx. Is CMS continuing to evaluate the area deprivation index? And do you look at articles like that when you're trying to figure out what to do next?
Yeah, we absolutely do. We're always looking at the new research that's coming out. It is an iterative process. The first time we ever tested a health equity related adjustment was in our ACO REACH model. That had never been done. It's a first of its kind benchmark adjustment. And that was a starting point. I think we've said publicly that, we're going to continue to learn and evolve our approaches. We're going to learn about what's working and what's not. We're going to have more research in this area, and we should always be incorporating the evidence into the way that we're thinking. We always have to balance stability as well for our model participants. If we change a lot of things from one year to the next, it can create volatility for a lot of these folks who are making the leap into a model that's time limited. And so we're always trying to balance stability with accuracy and making sure we are incorporating, again, the latest evidence and work. And I will say, Jim, one of the things that, and I think I said, we use a blend, right? We use both an area level index that taps into the given geographic area's need and level of underservedness. But we also blend that with looking at adjusting payments for, considering, for instance, eligibility for means tested programs like eligibility for or your dual eligibility status or low income subsidy status. So we use a number of factors to try to tap into underservedness. We already made changes from the first year of ACO REACH to the second year from PY23 to PY24. Across all of our other models that we're launching, we have slightly different variations to kind of, again, evolve as we're learning more and really start to isolate the most effective ways of supporting safety net providers in those underserved areas, but also hopefully bringing and attracting new providers in to close those access gaps.
Thanks, Purva. And then in the time we have left, let's explore a few examples of the types of models. And Dilly, maybe if we can start with the team model that's open for comment right now. Can you tell us a little bit about what that is and what it's trying to achieve?
Yeah, so TEAM is the Transforming Episode Accountability Model. It's a proposed 5-year mandatory model. It starts in January of 2026, and it ends in December 2030. And the main participants are acute care hospitals. The model initially focuses on 5 surgical procedures: lower extremity joint replacement, surgical hip and femur fracture treatment, spinal fusion, coronary artery bypass graft, and major bowel procedure. It allows for ACO overlaps, and participants are being asked to take accountability for ensuring people with Medicare receive coordinated, high-quality care both during the procedure and for the 30-day period following discharge from the hospital. The idea behind the design of this model is that bundling costs of care for surgical episodes promotes more successful patient recoveries, supports better communication between providers, especially around patient care transitions, for example, receiving post-op physical therapy, and may help reduce avoidable hospitalizations or hospital readmissions and other high-cost care. The model itself was designed based on lessons learned from previous episode-based payment models, such as our comprehensive joint replacement model and our BPCIA advanced model, as well as input from stakeholders in response to an RFI that we published in 2023. As part of taking responsibility for that episode, hospitals would connect patients to primary care providers to help establish that accountable care relationship that Purva and I keep talking about. and support optimal long-term health outcomes. Again, we're in the open comment period right now, and that ends June 10th. So if anybody's interested, we definitely encourage people to take a look at the proposed rule and offer comment if they're able. And I'll just add one other thing. Within this mandatory model, we have proposed a voluntary decarbonization and climate resilience initiative, which is the first of its kind and the first time ever that HHS is proposing to collect emissions data from providers, and represents a first step, but a strong step in our agency and HHS's effort to tackle health sector carbon footprint.
So thanks, Dilly. And for both you and Purva, like you must have to read thousands of comments from stakeholders. And I was wondering if there's any tips or anything you could give about when you read, since you're the audience for these comments that people are writing, in your mind, what makes a good comment and what distinguishes a good comment from all the rest?
You know, Jim, I'm gonna put like two hats on here. Like when I was in policy consulting, often supported a lot of different organizations in their comment letter writing, and being on the side is interesting as well. I will say, I think it's about solutions. You know, identifying places where you think ideas are good and supporting those, I think is always helpful, so people know that they're headed in the right direction. But also being constructive in terms of solutions and providing alternatives. So if something isn't going to work, what might work, or what are data sources that we might be able to use to help us understand what might work better. And I think I just used the word data. I think data and evidence is incredibly important. So to the extent that, you know, and it doesn't always have to be quantitative, it can be qualitative evidence as well, and qualitative research that really supports a policy alternative or a policy position, I think are really compelling.
Thanks for that.
Yeah,
I think that's a big help. Dilly, do you have anything to add?
Well, I was going to say, we are just getting our first comments in for the team model. And so your question is timely. Purva's exactly right. Data and evidence solutions. The only thing I'd add is being direct and clear in what the comments are meant to convey, whether that is a criticism, whether that is a new idea, whether that is a tweak, just being clear in the direction that you think the model should be going in the finalized rule.
When I was at CMS, I noticed that some organizations seem to think that comments were like voting, and if we got thousands of identical comments, that counted for more than one well-reasoned comment that gave specific things that they objected to, what we could do instead. What's your view of those comments that come in when it looks like they're form letters coming from thousands of people?
You know, Jim, honestly, our colleagues in the Center for Medicare and CCSQ and CMS might be better positioned because they go through rulemaking and for multiple rules every single year. At the Innovation Center, we go through rulemaking on our mandatory models, which are the, you know, again, the vast majority are voluntary. So we have a different like process. I will say sometimes taking like my CMMI hat off and thinking about some of the work that I did in consulting, you know, that also, I think sometimes form letters or knowing that there are areas where there is a lot of interest also helps, right? So it's, I think, a little bit of both, having the specific sort of policy alternatives, the data and evidence to back it up, but also knowing that there is robust interest in a particular solution, I think really helps. So pairing the two together, I think is probably pretty effective.
Great, thanks for that. And then let's turn to the AHEAD model. One of the interesting things about that model is that it has been extended to run over 10 years. What led to the decision to have these longer model timeframes? And can you also tell us a little bit about what the AHEAD model is?
You know, it's you talked about AHEAD, Jim. We also have our Making Care primary model that's running for 10 years, and our guide, our dementia model, that's going to be running, I think, for 7 or 8. And normally, historically, at the Innovation Center, our model tests have been 5 years. But one of the things when Dilly was describing our new strategy, well, it's not really a new strategy, it's our strategy, our 2021 strategy. We looked back and tried to see like what are some of the lessons we learned from this first decade of testing. And one of the things that we learned is that in certain areas where you are making investments, and in some of our sort of population-based models, or ACO models, or primary care-based models in particular, it is difficult to detect changes in quality and total cost in a 5-year period, right? When you're investing in things like prevention, trying to move care upstream, we know that seeing the results of those kinds of investments can take a little bit longer. So I'll give you one concrete example. In one of our previous primary care models, we found that practices that were participating in that model really slowed growth in emergency department, ED visits, emergency department visits. And we saw some of those changes and those reductions persist and grow over time. So we have a 5-year model, and really seeing these kinds of results and changes in utilization accelerate in the later years of the model, like years 4 and 5 of the model. But the model doesn't achieve kind of the savings bar, the net savings bar, because those changes in utilization, you're making all these investments, you're transforming care as a practice the first few years, and you're not capturing or able to impact utilization until you're a little further down the road. And so we thought, for some of our models, depending on the nature of the model, the nature of the investment, what we think the time horizon is going to be able to actually see those changes in quality and cost, we want to be able to test over a longer period of time. And AHEAD is one of those models, because one of the things that we're trying to do there is support states in really redesigning the funding in their state, and really, again, investing in primary care and community-based care and moving upstream in a state total cost of care model. We know that's going to take some time for states to put those pieces into place, to get other payers aligned, and then to be able to, again, see those cost and quality shifts is going to take a little bit longer.
Thank you. One of the key messages of the Biden administration seems to have been lowering high drug prices. And there's been a lot of talk about the Inflation Reduction Act and drug price negotiation. Does the Innovation Center also have programs to improve drug affordability? And can you tell us a little bit about those?
Yeah, I'm happy to. And then Dilly, you should jump in too. And our colleagues in the Center for Medicare are incredibly busy with IRA implementation. But at the Innovation Center, we're also looking to see how we can complement their work and push into new areas as well. Prescription drugs, obviously, they're a top priority for the Biden administration and for CMS. It also continues to be a top of mind issue for the general public. We've been working hard to try to address drug accessibility and affordability issues over the last year and a half. Dilly referenced that President Biden had issued an executive order on lowering prescription drug costs for Americans. That was, I think, in October of 2022. In February of 2023, we actually published a report in response to that executive order, where we outlined 3 models to address issues of affordability and access, especially to novel therapies. And we've continued to kind of build those models out. Those 3 models that we outlined in the report were the Medicare $2 drug list model, an accelerating clinical evidence model, and then a cell and gene therapy access model, which we actually announced earlier this year in January, and it goes live in January of 2025. Happy to talk about any of those a little bit more, but I just kind of round that out by saying that the 4th strategic objective that Dilly talked about was addressing affordability, and the parts of our portfolio on the drug model side are really key to that strategic objective in particular.
Thanks for that. We're running a little bit short on time, so I'd love to explore those further. I have a couple of sort of wrap-up questions. It occurred to me that with more than 50% of the population enrolled in Medicare Advantage, a move to get 100% of Medicare beneficiaries in accountable care relationships by 2030, at some point, does the original Medicare fee-for-service program become irrelevant, or will it still play a role, do you think?
Yeah, I mean, I think when we think about our work, we think about it scaling into the permanent Medicare program, right? And improvement and iteration on either new programs that Congress authorizes or existing programs. You noted that we have some pretty bold goals moving into 2030. We think that we've made great progress over the last few years, but we still have a long way to go. So I think I'm less worried about, phasing out of, fee-for-service or original Medicare, as much as moving as much of payment as possible into value. And there are ways that, for instance, some of our models are contributing to changes in the physician fee schedule and to fee-for-service as well. And we can, share some of those examples. But for instance, we've, tested things like community health workers and care coordination in many of our models, and those are now new codes that have been added to the physician fee schedule. So I think I don't think it's quite such a stark line in the sense that for instance, in the ACO work, I should have said we have a permanent program. We have the shared savings program, and so we have had models that have scaled into the shared savings program, features that have scaled into the shared savings program. And so I think of it as a feedback loop.
Thank you very much. And then both of you mentioned this a little bit earlier, but I think it bears repeating now that we're towards the end. Some have criticized the Innovation Center as being a black box and they don't know how it works. And what have you done and what can stakeholders do to sort of demystify that and engage, and how have you worked to improve transparency?
Yeah, I'm happy to start. As Dilly mentioned earlier, the fifth objective for our strategy is partnering to achieve system transformation. You can't do this work in a vacuum. You can't do it without external engagement and transparency. So those partnerships include within government partners. So I talked a lot about, our colleagues in Center for Medicare, but there's other parts of CMS. I talked about HRSA. It's working across the agency and across the department to be able to, again, test things that are meaningful and impactful to the end users of the health system, but also our external stakeholders. So we take our communication about our work, as Dilly said earlier, very seriously. Starting back in 2022, we've undertaken a number of activities to better educate folks about our work, but very importantly, it's bidirectional to take in feedback from on how we improve our model portfolio, our operations. For instance, twice a year, we host beneficiary listening sessions to incorporate patient and caregiver perspective across the life cycle of our models. We just had our last one on April 24th. We also have the Healthcare Payment and Learning Action Network. So for those of you that want to, stay involved or learn more about value-based care, that's a public-private partnership that CMS funds, also called the LAN, where we're always partnering with the LAN, and there's various LAN initiatives that help us get external input through those forums. Talked about issuing RFIs, engaging in rulemaking for our mandatory models. And then we've also, back in 2021, made a commitment to improve our communications. And I already talked a little bit about one area of real commitment was working more closely with beneficiary groups and beneficiaries and beneficiary experts, so that we're incorporating, again, the end users of the health system into our thinking. And then the second was also researchers, that we generate a lot of data and information from our models. And so one of the things we started to do is release data into something called the Virtual Research Data Center, or the VRDC. I think we have over close to 20 models now that allow external researchers and organizations to directly access those data files and then conduct independent analyses that generate insights, learnings into our models as well. So lots of different ways that we can be transparent, both with groups. There's formal mechanisms, informal mechanisms, public listening sessions, but also with an eye to the research as well, because what we're supposed to be doing is learning and iterating at the Innovation Center. And so engaging more with the research community is really important as well.
Thank you for that. And so, Dilly, if there was one thing our audience ought to remember from the remarks today, what would you say that one thing is?
I think it would be that the actual delivery of care is changing extremely rapidly these days. And it's driven a lot, not just by government actors like us, but also demand from patients and providers. Like we hear all the time from providers and ACOs and others that they find a lot of value in the models that we create and the general movement towards value-based care. There's less administrative burden. It helps physicians focus on their patients. It helps, management avoid burnouts among their staff. And, you can go down the list of the benefits. So that would be the one thing that I would kind of highlight here as a summary of what we do and what we hope to achieve.
And Purva, we'll give you the last word. What's the one thing in your view our audience should take away from today's conversation?
Yeah, we've made a lot of progress in the last 10 years to take value-based care from a nascent concept. We didn't know that any of this was really going to work in 2010 to this at this scale to one that's really part of our healthcare landscape. We continue to face a lot of challenges in terms of beneficiary access, equity, workforce burnout. And I think it's more important than ever that we continue to shift away from that fee-for-service payment system to a value-based payment system that has the flexibility and the mechanisms to support coordinated care, communication between providers, team-based care that can support a healthier workforce. And so I just, encourage folks to continue to stay involved, to continue to learn, and to think about ways that value-based care can be a solution and a mechanism for addressing those problems. And I also just want to say thanks to everyone that joined the webinar today and for all of your questions. I'm hoping we can get a copy of those from you and your team, Jim.
Of course you can. And that brings us to the end of this month's Northern Virginia Health Policy Forum. I'd like to thank Purva and Dilly for joining us today, but more importantly, for both of your public service and being good stewards of taxpayer dollars and improving the lives of people with Medicare and Medicaid. We really appreciate that. And thank you for doing that and for your agency also doing that. We'll have our next forum in June, so we hope you can join us for that. Thanks to the Applied Policy team, especially Marlo and Allison. Marlo chatted how you can sign up for our newsletter if you want to stay in touch and be on our list for future forums. So thank you very much, and I hope you all enjoy the rest of your day.